Right, time for our second speaker of the morning. Dr. Farzana Hussain is GP Principal at the Project Surgery, and let's see if I can find the right place, and formerly co-chair of the NHS Confederation PCN Network and Clinical Director of the Newham Central 1 Primary Care Network. I have to confess, I'm not up to speed on all the different names of all the groups that people sit on, but I'm very conscious that we have the benefit of your first-hand frontline experience in London in a busy practice. So welcome to you, and then we'll be taking questions from you as well.
Hello, everybody. Can you hear me all right? Yeah, well, thank you so much for having me today. It's my first keynote, so I'm very excited, and really nice to see everybody in the room after so long, and hello to everybody virtually as well. I'm a GP, not too far from here. I work in East London, so just about half an hour from here, I run a list of about 5,000 patients. And I've had various roles, thanks to my mischief over the years. It's my 25th year in the NHS this August, and I've been a GP 21 and 20 years in my practice at the Project Surgery. And I was quite interested in primary care networks that are 3 years old now, so I've just stepped down from my role as clinical director there and got so excited about them that actually I was part of the National Primary Care Network, co-chair of that. But I've just recently stepped down from appraisal, so it was really interesting. Had a really positive experience of appraisal myself. And in fact, my last appraisal was an appraisee. My appraiser was actually very helpful because sadly I recently got divorced after 25 years and didn't have a lot of confidence travelling. And my appraiser was helping me think about places I could go to. And we thought Copenhagen might be quite nice. So appraisals can be quite positive. He said it's quite safe and lots of buyers. So I found my appraisal really very helpful. Next slide, please. I think I've got a slave doing my slides for me. Or no, maybe it could be me actually. Oh yeah, there we are. So this is me. This was more than 2 years ago, before the pandemic, where we were blessed with Dr. Nikki Kanani, our primary care director, coming to visit us. And you'll notice something about my team. My team's changed a little bit, but we're not that diverse, but we are we're all female, all 10 of us. We now have 2 Caucasian people and 1 African person, and Newham is 74% BAME, and we have we don't have the highest poverty rate now, thanks to the Olympics, but we have pockets of lovely gentrification like Stratford, where I live, and then where I work in Plaistow, just a mile away, it's really poor and people are really struggling. We had the highest furlough rate during COVID, highest unemployment rate, and people are really struggling between heating and eating at the moment. So I had to put this in to have a little gloat myself. So I was fortunate enough to win GP of the Year award in 2019. The reason this was really important to me was because the application that me and my salaried GP put in, we thought, shall we go for it? And we thought, why not? And we were writing this up at 11 at night, and I had a wonderful GP partner who was my trainer, and sadly he passed away 9 years ago when we lost him to suicide. And I think it's important to bring this up because this is a real thing that happens. It happens to doctors, it happens to nurses, and really it's never left me. I was 40 when it happened, and it absolutely changed my life, and I wondered whether I would be able to carry on as a single-handed GP. And we were just talking about leadership earlier. It was actually my healthcare assistant, who was only 24 at the time, and she said, let's take a day at a time, Farzana. I had a 9 and a 10-year-old at the time. I didn't know whether I'd be able to run a practice, run a business on my own, and it was this lovely 24-year-old who gave me strength. So anybody can be a leader, and here we are. still 10 years on, so I still get a bit emotional thinking about Peter. He was absolutely gorgeous, lovely man. But, we took a day at a time. But how can we, as a system, support those people so that those sort of tragedies don't happen again, particularly at the time we're facing at the moment where a lot of people are burnt out after COVID. So then COVID came after the celebrations of 2019 and getting all dressed up. Suddenly we were all in scrubs and overnight trying to work out how to run infection control compliant procedures, reading documents every single night, never heard of a disease called COVID, so it was working all day and being back in medical school at night, thinking about how to keep staff safe. As said, lots of my staff are BAME, and sadly the 5th doctor in the country to die was Dr. Yusuf Patel, who was a very dear friend of mine, and we used to work on a GP federation together, and how we could keep our patients safe, because Newham sadly had the highest COVID death rate during the first wave. But all was not lost. We had to think on our feet. And one of the reasons I absolutely adore being a GP is because we're small, agile organisations. There's a ton of us in the team. There's 5,000 patients. Small practices are perhaps not fashionable at the moment, but I'd like to think we provide really good care. And why do we do that? Because we can turn very quickly. So something I noticed, the lockdown was about March 2020, and by May 2020, my children's immunisation rates were going down because we were telling everybody to stay home. And I thought, oh, crumbs, we've got an infectious disease called COVID, and the way my kids are not coming for their immunisations, we're going to have a comeback of measles or diphtheria. So I thought, how can we sort this out? And we thought, well, if McDonald's can have a drive-through, we can have a drive-through clinic. So the muck immunisations was born. And you can see a picture here of my practice nurse. We just used to get people to come in their cars, and we would actually immunise the babies in their cars. Not everybody in Newham has a car, so we had to think about a little bit of quality improvement there to think about what to do. So if you're in Newham, any buggy, any pushchair, we class as a vehicle. So we were able to, even with your learner plates on, so we were able to bring people in. We're fortunate that we're in a converted house in a corner, so we were able to actually immunise children in our front garden, and it wasn't too cold. And one of the nicest things that Dad said to me, because we were just trying it out, we were not sure whether this would work, and his little baby, it was a windy day, it was a bit cold, and I said to Dad, I don't know if we're doing this right, and he said, I can see you're trying your best. And that was important. And then, what else? So I'm a bit of a fan of primary care networks, and that's and what are primary care networks? So I love running a list of 5,000 patients, but there's things that I just can't offer my patients. So we don't have phlebotomy on site. We don't manage to initiate insulin for our diabetic patients because we just don't have the size. And one of the great things that I think has happened with the NHS long-term plan in 2019 is that now we've got these groupings of practices called primary care networks. And the aim is to not just work in general practice, but to work with our community trust, with our voluntary sector organisations, and really provide that integrated care for our population health. So one of the other issues we face in Newham, and in fact it is everywhere, but in London, is that sadly my teenagers keep getting stabbed to death. So I have had 3 patients aged 15, around 15 over the last 6-7 years, stabbed to death. That's more children I've lost than of childhood cancers. So it's not a medical condition, but actually it's affecting my patients. They're dying. So through the primary care network, because I was clinical director for 67,000 residents, so that's more than an eighth of Newham, we were able to bring in a national health inequalities project. And you may or may not recognise this young man on the left. Baptista sadly got stabbed to death in the middle of the afternoon. He was one of my patients. His family have given consent, has been on the news. A 15-year-old boy at 3:30 in the afternoon on his way home from school, and my daughter is just 4 months younger than him. So when he was 7, his mum used to say, "Does your daughter talk back?" I said, "Yeah, my daughter talks back." And when he was 11, his mum would say, "Does she not answer her phone on the way back?" I said, "No, mine doesn't answer the phone." And it was an absolute tragedy to see that he never saw his 16th birthday, and my daughter's 18 now. So I felt like I really needed to do something. And because we're part of a primary care network, and I was fortunate enough to be part of a national inequalities programme, we partnered with West Ham United Foundation, because a lot of our young boys and girls like football. They're a voluntary care sector organisation, and we have a youth worker that works with our GP practices and talks to our young people and actively finds them. So this is an example of something that can be a bit unusual but really great in general practice. So even though we're burnt out, even though we're busy, there's real opportunities to make change for our patients, which is, I think, for most doctors and nurses and managers in the room, that's what we want to do. With COVID happening, I think I was talking to Samira earlier and saying how I think it did affect all of us. It certainly affected me, and I wanted to think about what I could do. And with the highest death rate in the country, and knowing that BAME people were sadly genetically passing away more, I felt I wanted to do something. So I just got on Twitter and started making my own video messages about why it's good to have a vaccine and why it's good to wear your mask. And it got a little bit of attention, and before I knew it, NHS England were asking me to speak. So here's just an example of what I did for Boost Day. And I got my picture in a lot of magazines after that, so that was quite nice. But I think it was a really important message, because we know, anybody who's read the Marmot review, that sadly even in 2020, if you're a BAME woman living in a deprived area such as I am, you die 10 years younger. So if we just think about that, we're in 2022, we're in one of the most iconic cities in the world, yet if you're a woman and you're BAME, you will die 10 years earlier. So I think we really need to do something about that now. So our doctors of tomorrow, so I had to get a proud mum moment in. So this is when my son was a baby. That's one of his better pictures. He didn't always behave that well, but he looks quite cute in that picture. And then on the right, not so cute anymore, but proud mum moment. He's a first-year medical student at Manchester. And one of the things that surprised me, actually, and shocked me, is he said, "Oh, Mum, I don't want to work as hard as you and Dad." His dad, Mike's husband, is a surgeon, a consultant surgeon. And I said, "What do you mean?" And he said, "No, I see you doing all these emails at 11 o'clock at night, and I don't want to do that. And, I've looked into Google, and if you work with Google, they give you free lunch." And he's really attracted by the prospect of free food. And it got me thinking about, is this just a generational difference? Is he 19? Am I just getting old? I don't mind doing my emails at 11 o'clock at night, because actually then, if I want to, I can have 9 in the morning free. It's not like I'm working 24/7. But actually, if I feel it's important, I have a real sense of purpose, and I really enjoy my job. And I'm wondering how I can inject that sense of purpose and enjoyment into a generation who actually can get his takeaways in 2 minutes, whereas when I used to get a takeaway growing up in Preston in Lancashire, it was a whole day out to go to the Chinese takeaway and carry the bags. It was the whole ceremony, whereas now it's just eat. So how do we make our doctors of tomorrow want to stay? And I think I have to admit that I'm getting older and that there is generational differences, and just telling him he's lazy probably isn't going to work. Although he's a bit lazy, he doesn't do any washing up or anything. So there's lots going on at the moment. We're tired. General practice is having a bit of a bashing, actually, isn't it? That, we're all closed and, we don't see anybody face to face. And we're in this transition period where I don't think our public are fully ready to embrace all the digital advantages that we do have. A face-to-face conversation might not be the best for every single patient, but how do we bring our public with us on that? And how do we actually accept that people alone lonely. I was just talking to Dame Carrie earlier about how nice it is to be able to touch her and to stroke her, because you just can't do that. And we've never met before, by the way. But it was just really nice for me to be able to do that, because it felt really human, and you can't do that through a screen. And actually, are our patients missing that? Do they actually just want to sit in a room with us? Do they want to be heard? And do we have the resources for that when we're 6,000 GPs short, if not more, and more and more retiring or going into the private sector, actually, if you're younger. At this same moment in time, we're trying to create all these. We've got some great roles. We were talking about multidisciplinary working earlier. Primary care networks have up to 15 different roles, from occupational therapists to pharmacists, but we need time to embed them, that they're not grown yet and they're not doctors. They offer something different. So in this transition period, how do we hold our nerve? But I do think that every series of opportunity, great, well, you can read it. We are all faced with a series of great opportunities, brilliantly disguised as impossible situations. At the moment, I think it does feel a bit impossible. And for me, it's just about holding that and accepting that it is impossible, but out of impossible things come great things. So where I am in Newham, we have the biggest Ukrainian population in London. And what do I say to my patient who I spoke to only last week, who said, my husband and my father are fighting in the Ukraine war, and back home, and I've just got a little baby, 6 months old, and I don't know whether I'm going to be able to speak to them. I don't know if they'll die. A few antidepressants aren't going to really hit it there, but these are real life problems that we're facing. How do we support our communities? And then I had to end on this one. I was so chuffed that when the NHS had its 72nd birthday in 2020, I was chosen by the photographer Rankin, who I probably was the only person in the world who'd never heard of him. Apparently he photographed the Queen for her Jubilee, and I didn't know. I was representing general practice, and I just loved that photo. He made me look slim and really elegant. So I leave you with that, because that's definitely my legacy. But I'd like to think about what legacy we leave as a profession, so that in 20 years' time, I don't need to be looking at stats from Marmot to say that actually BME women are living 10 years shorter, and that we haven't lost people like my son to Google just because he gets free food. And apparently they have these thinking pods, and he just wants to sit and think in these thinking pods. So what can we learn from other industries so that we can make our NHS the best? Because I'm so proud to work in the NHS, actually. I'm very emotional saying that, because we are still free at the point of service. And I don't know why I'm crying. My parents came from Bangladesh just before it became Bangladesh, and they tell me stories. My dad's a retired anaesthetist, having given 25 years. They said that people just died because they couldn't afford the care. Thank you.
It must be being in the room with all of you is so nice that I've got really emotional.
I've teared up as well. Right? We're all having a moment.
It's so nice to be in a room with everybody again.
Yeah, it was such a lovely and thoughtful presentation, and you didn't, shy away from really difficult issues, including suicide affecting people, and the reality of some of the kind of horrible, crimes that are affecting your constituency. So, the kind of knife crime and so on. One of the first things I wanted to ask about was, that COVID has made huge demands on GPs, and I wonder, have patient expectations changed? You sometimes hear anecdotally that there's more anxiety and therefore perhaps to some extent more complaints or even abuse.
I think it's two things, Samira. I think when COVID first happened, so the first lockdown, so when we were doing, for example, the drive-through clinic, there was a lot of understanding from patients. So, even if you're immunising a baby in a front garden, which sounds weird, rather than because it was okay. now that has changed, and I think people, I think we've all been affected by it, and people are tired. I think you hear about a 6 million or a something million backlog waiting for your appointment, and that just sounds so large. But actually, what does this mean? So when I was in clinic yesterday, a third of my clinic was patients saying, well, one of my patients said, I've got an 18-month wait for the respiratory clinic for my chest. Is that correct? He thought that they'd made a mistake, and I was like, that is actually correct. And people are upset, and of course there's GPs, we're the face of the NHS. So well, what are you doing about that? Another patient, sadly, he was just upset, and he said, do you want me to die of my heart problems? Is that what you want to happen? So people are very, very upset and anxious, and the waits are very, very long. And sometimes it gets into aggression between GP and patient, because GP say, well, it's not my fault. But I think it's not my fault, but we also need to understand that people are very distressed at the moment.
Yeah, and also presumably people are reporting later in terms of the development of serious conditions. So what impact is that having on GPs?
In 21 years as a GP, I've never diagnosed so much cancer. So between November and now, we just did an audit. I've got a list size that's very young, so we would normally diagnose 2 or 3 cancers a year. Me and my doctors together have diagnosed 6 in the space of 3 months. And a lot of people were just not coming out during lockdown. And then there's a secondary thing. So I mentioned earlier that Newham had a very high furlough rate. So a lot of those people are unemployed or on 0 hours contracts. They can't take a morning out to think about, oh, is this a problem? Is that not a problem? When he's got a whole family to feed. So a lot of things like prostate cancers we're picking up very, very late at the moment.
Okay. Question that's just something you said. I have to say, I feel a bit sorry for your son to bring him up at the GMC conference. So, bring him in next year and get his point of view. Could we admit, says Rachel R., that your son is right and try to make medical roles more attractive to the young, rather than thinking that we have to enthuse them to work harder?
Well, yes, I think this is the question, because I started off, as all mums do, quite bossy, and it's like, what has happened to you? You're just a lightweight. Your dad's worked hard, your mum's worked hard. And then I thought, actually, he is a different generation, and maybe just telling him that the way we did it was the right way won't help, and actually I'm concerned that he'll go somewhere else. So I think we do need to, for all our young children, he's only 19, I'm working with a fabulous locum GP at the moment. She works with me and she's second year qualified, and she said, absolutely love being a locum. I wanted to be a doctor to come and talk to patients and sort my patients out. I don't know what it is you do, Farzana, with all this CQC preparation and all this preparation and all your accounts and all this, and she just doesn't want to know about it, the management of running a business and running a practice. So I think there is something about listening to our younger generation if we want to keep them in.
Yeah, and I should say, Google, the reason they give you free food is because they expect you to be there from dawn until very, very late at night.
I must tell him that, you see. He's just eating.
Right, lovely one here. Thank you for a really touching presentation. As a BME woman in medical leadership, have you ever struggled to feel heard, and how have you overcome any challenges?
Great question. So until about 2 years ago, I used to just walk away. So I've walked away from quite a few positions. I was Federation Board Director. I was an LMC board member. It's only recently, I think, since COVID actually, since COVID, everybody's had a bit of a reset, and I thought you only have one life. I talk back more now. I never used to do that before. I just used to walk away, but I talk back more, and I think I need to do that not just for myself, but I've got an 18-year-old daughter, and I want to make sure that she does. So it's just little things for me where I haven't even, when it's been said to me, so somebody said, you really don't want to go for the chair position of the federation, do you? Because you've got a husband and you run your own practice and you've got to look after your kids. And I was like, yeah, you're right. And then when I thought about it, I thought, I would never say that to a man, or in fact another woman. So there has been those, those what I would say microaggressions, and they're always there. And I didn't recognize them before. But it's great that we talk about it more now, because I don't want my daughter's generation to walk away. I was a bit of a coward and just walked away more.
I do think it's true across professions, not least for doctors. But as you get older and you've attained a certain amount of seniority, I think women in those positions have more confidence to challenge and want to make it different for younger women.
For somebody
coming
else,
up to,
yeah.
absolutely.
Yeah, a duty.
Two of the big issues in the headlines of late have been living with COVID, quotation marks, and access to HRT. What can we do to better enable primary care to support health and well-being and quality of life? And that's two really good issues put together, isn't it?
Living with COVID is really hard, isn't it? Because I'm working in an area where still, sadly, only 2/3 of people have even had one vaccine. So that's 2/3 of people have only had their first COVID vaccine. The rest of us have had 3, at least, if not 4. So when I'm looking at, so although NHS England's infection control procedures have gone back to pre-pandemic now, we're having to make risk assessments, you know, every single day. So I know that I'm working in an area where there's still a lot of COVID, or you know, could be a lot of COVID, people are not immunised. So on a very micro, like practice level, I'll make sure that my elderly, we just book them in a bit later so that we are not, the waiting room isn't full. So, so little things that you can have influence over in general practice. On a wider scale, it remains to be said, I'm concerned about what living with COVID means. Very nervous about this winter. I know that, you know, we're down now, it's only 1 in 20, but this winter, what will happen with the NHS being so under pressure?
And long COVID, are you seeing much less?
Seeing a lot of long COVID, and we're still, I would say, only in the early stages of understanding this illness. It's not just respiratory, you know, there's the whole fatigue, but there's other, every single organ can be affected. So we're still learning about long COVID, and yeah, it's around, I don't even know what the prevalence is. So I think we're underdiagnosing it at the moment.
Are you sending people to these so-called long COVID clinics?
There are the long COVID clinics. Obviously, there's still no cure for long COVID. So one of the things that I'm speaking to patients about is long COVID clinics. Again, they're there to help rehabilitate, but there's no cure, which is frightening for people who have been active, you know, bike riding, cycling, at the gym, who literally can't get out of bed now.
Yeah. Right, the HRT aspect of it, can you address that as well?
That's hard, isn't it? That's hard with
practice?
supply. So this is something that I'm personally very interested in, being 49, thinking this is going to affect me in the next year or so. So I think that at the moment, the supply issue is the massive problem, because we're rushing to like only 3 months worth of HRT. And it's really interesting because I became a GP in 2001, and it's interesting seeing cycles. So in the early 2000s, HRT was thought of as like poison. You know, we won't give it to anybody as it causes breast cancer or heart problems. It's interesting to see now that we've you know, shifted the other way. And I suppose a lesson for me is not to be dogmatic about anything in life. So I do prescribe quite a lot of HRT as being a female doctor, but the supplies are a real issue at the moment, and it's causing distress for women.
Christopher Jones asks, what would you change in your practice if you had a magic wand? And your presentation was immense, which it was.
Thank you, Christopher. What would I change? I would have more time to train and supervise these brilliant new roles that are coming in, like pharmacists, so many, and be able to have that time and have built-in time to think. I don't think we have enough time to think in the NHS because we're often firefighting, and I think that we need to value thinking and planning time, and my quality improvement training really helped me there. It was the first time when I became quality improvement trained in 2016 and said it's okay to think. We seem to still measure things on how many patients did we see, how many contacts did we do, without the quality of that. Something might be fine at 5 minutes. It might be that you just need a repeat prescription and it's easy and I give it to you. And something might take 30 minutes. And we still measure everything on the, we seem to assign quality to how many 10-minute consultations did Farzana get to. And I think that model is wrong.
Yeah. Well, two good questions. One following on from that. Do you feel the regulation of both doctors and GP practices as healthcare providers is proportionate?
I think regulation is still a scary word, and Dame Carrie was talking earlier about culture. I think culture works both ways. I think we need to think of this issue as a shared issue rather than the regulators are coming to get me. Because, I mean, I get nervous before my CQC visit. I get a bit nervous before my appraisal, although my appraisers generally are very positive and think about my life as a whole, hence, Copenhagen. But I do think that we need to work together on that. I think at the moment, I would say CQC is not proportionate because we're using the same module kind of for hospitals and general practice, like completely different organisations. So I think it's not proportionate, but I do know that CQC are doing a lot of work to look at that actually themselves as well.
Interesting. Hania S. asks, how do you firstly deal with unconscious biases or microaggressions on a personal level? You did mention that a little. And secondly, could you advise about speaking against it and raising it as a concern on a professional level?
So I think it takes quite a lot of courage. So I said I wasn't really brave enough before. I've been very supported by the NHS Confederation. I used to work with their PCN network, but they also have a BAME leaders group, and I find them very useful because when we hear the stories, they're actually very similar. Everybody's got a very similar story, so it makes me feel like, oh, it's not just me, because something about unconscious bias is that nobody means to do it. I mean, I have unconscious bias. So I was walking, I live very near Westfield Shopping Centre, so I'm always in Westfield shopping, and I was walking up some stairs the other day and I was noticing how hard somebody in a wheelchair was, they were waiting for the lift, it was bank holiday, everybody was busy, and I suddenly thought to myself, I don't think about it. I just toddle up the stairs and I don't think about it. So I think the whole idea of unconscious biases is just about raising that awareness and not being scared to do it. Because before I felt like I didn't want to cause a fuss and if I said anything. And now I think actually if I can see something and I don't raise it, then I'm not doing my duty, because there might be people who want to help. And not within the ethnic minority or not a woman, that allyship. I think there may be a lot of people that want to help, they just don't know, but we need to help educate them to our experience because they don't have my experience, I don't have their experience.
Fantastic. Anatoly says, in London, a lot of GP practices before COVID stopped providing long-acting contraception to women. How's your PCN addressing this?
Oh, you're right on the money, Anatoly. Yes, so our PCN is trying to look for particularly IUCDs. We have a big wait, even with our sexual health clinics, for IUCDs. So we're thinking about, well, not thinking about, we're trying to train up a PCN level nurse who will do that, because there's a real need. Again, Newham, where I work, is a very young population, so we've got a lot of need for contraception. Our sexual health clinics are not meeting that need, and that's one of the advantages of PCNs. Not every single practice has to do it. We can do it at scale.
Excellent. Did the recent anti-GP media coverage affect you and your colleagues personally? So I don't know if they're thinking of any particular stories, but I guess there often are news stories, aren't there?
Definitely. So it was the face-to-face. I think people saying to us, oh, you're really lazy because you're doing a telephone triage. Well, we were doing a telephone triage for 10 years. We've been doing that since 2013. So it wasn't new for us. But it was the equating of that face-to-face must be the only way to help patients is a very... it's very yesterday, and it's how we can bring our patients with us, but have that, it all goes back to trust, really. I think, as Carrie was saying earlier, it all goes back to trust.
I mean, there's that underlying big issue, which has been there for years, which is the number of GPs who are retiring and who's going to replace them. What are your thoughts about the kind of medium-term future of GP practice?
I'm really scared, actually. I used to think I was really young, and then my accountant called me 2 months ago and said, we need to talk about your pension. And I said, we don't need to talk about pension. I'm only 49. I don't want to think about that. That's scary. But we have a real issue as well with pension and pension taxation. So a lot of people who are just 5 years older than me are leaving the NHS because they're having to pay tax on pension that they haven't got yet. So there's a whole financial element to that. So we're losing a lot of people maybe 5 years earlier than we would have liked to. And then we've got the young ones who want to, my son who wants to work for Google. So I just think we need to think about how we retain, because otherwise we're going to be in dire straits. Other roles are absolutely fantastic, the pharmacists, the other roles, but they're not GPs, and we should not treat them like GPs. That's not fair to them. A physician's associate stands in their own power, they stand in their own skills, but they're not GPs. And trying to turn somebody into something they're not, it is quite dangerous for patients, and we'll lose our multidisciplinary teams.
And is there one thing that you would say is needed, thinking of where you're speaking, that could be done to change the way GP practice operate, or the framework in which they operate, that would be beneficial?
Yeah, it's a big ask, but I think it's very achievable. We need to break down that door between hospitals and GPs. We really need to work more together. So this 6 million, 7 million, whatever million waiting list it is, I firmly believe that if primary care had the resources and primary care, so if we sat with consultants, with patients, I'm sure we could halve that waiting list. I actually believe we could halve that waiting list, because we know our patients. Sometimes they don't always need that second care. Sometimes we just need advice. So I think there's a more smart way to do it, rather than me write a letter and send Samira to a hospital who'll see her 18 months later. There must be a better way to do that in 2022, when we can go to the moon and back.
Absolutely. Well, let's get. You need to be spending more time with Sajid Javed sorting all this out, I think. Farzana, what a presentation. Thank you so much.
Thank you.